Hello and welcome to the lecture where we do some applications to pain management, talking about osteoarthritis and then getting into rheumatoid arthritis and also mentioning gout as well. First, just a couple quick review items. There's a brief case here about osteoporosis. We have an 82-year-old man, started on alendronate 6 months ago. He complains of significant reflux, confesses that he often takes the medication with food as he forgets to do so beforehand, and admits sometimes laying down a bit before breakfast. Reading past clinic notes, there's some other compliance medication related issues that you notice, and which of the following medications might be a better option for him. So with bisphosphonates, they're basically all the same. You have oral, as far as oral options go, there's really no difference. The only one that is different is choice C, which is zoledronic acid or reclass. Certainly you could try to see if there's some education to do with this person before switching him. Maybe he has a caregiver that helps him out, or a spouse or somebody who could remind him, but sometimes it can be difficult to ensure adherence, and if he's having issues with that, it can be damaging to the esophagus over time. So certainly see a yearly injection might be a better option for him, assuming his insurance pays for it, and that's zoledronic acid. Okay, we're going to talk through a chronic pain case and do a practice calculation here. So if you've been struggling with the calculations, maybe this will help. But really, it's just all about canceling units and figuring out your conversion. So this is applying this to maybe a more realistic scenario as opposed to just asking you to do a calculation. So you've got MM, 54-year-old male, significant pain due to recent tumor resection surgery, currently using 10 milligrams IV hydromorphone per day via a continuous infusion plus patient-controlled analgesia or PCA, and an average of 20 milligrams of oral hydromorphone throughout the day too. You want to convert his regimen to an all oxycodone regimen for outpatient use. So this is a pretty common scenario. You have somebody inpatient who is getting a fair amount of IV pain meds, and you want to convert them to something long-acting outpatient. Remember, your really common conversions as far as long-acting non-IV options are going to be oxycodone, ER, morphine ER to a lesser extent, doesn't get used quite as much, and then fentanyl patches. It's really going to be those three. So first you need your conversion factors. So hydromorphone IV is about 1.5 milligrams to 20 milligrams PO oxycodone. Hydromorphone PO is about 7.5 milligrams to 20 milligrams oxycodone PO. So we can figure out his total amount he's using and convert each one of those separately to, because it was given on the previous slide, so we know he's using 10. I'm not going to make you calculate, like I'm not going to tell you he's getting 0.03 milligrams per hour in a 24-hour period. It's just kind of excessive amounts of calculations at that point. So I'll give you a total that makes a little bit more sense. Or I might give you like a BID or something like that, but it'll be a little bit easier math than having to calculate like a total drip infusion rate. So anyway, you have hydromorphone IV set up here, conversion. So we've got 20 milligrams of oxycodone, and then our conversion here is going to be the total he's using in IV hydromorphone, which is 10 milligrams IV, and then putting our conversion factor on the bottom here. And really it's about canceling out your unit. So if you cancel out your IV hydromorphones, you end up with just milligrams of oxycodone. And oxycodone is only PO, right? There's no IV form of it. So 133 milligrams oxycodone equals the IV amount that he's been getting in hydromorphone. And then if you do the 20 milligrams oxy times 20 milligrams PO hydromorphone over the 7.5 milligrams conversion, you end up with about 53. And that makes sense, right? Because the PO hydromorphone is so much less potent from a conversion factor point of view than the IV. Even though he's getting more, it's going to be significantly less. So now that you have your two oxycodones, you can add those together, and you're going to get 186 milligrams total PO oxycodone. And now you multiply for cross tolerance. Cross tolerance, I think, is probably the trickiest part about all of this. The math itself is relatively simple, but this is one that trips people up. And just remember, the point of this is because every time you would switch from one agent to another, the theory is that, you know, if you're going from hydromorphone to oxycodone, that patient who's never had oxycodone is going to get some inherent benefit just from being on a new medication, so they aren't going to need the full conversion. So your target should be about 50 to 75% of your total. So you're taking away 25 to 50% in favor of the new agent's cross tolerance, providing that additional benefit. So in this case, you would look at what is available as far as products on the market goes. And for example, oxycodone extended release, or OxyContin is the brand name. So that's oxycodone ER, and that's going to come as a 60. It comes as a 60 milligram product and gives you 120 total per day, which falls into your range. So you don't need to be. There's no like prescriptive, recommendation for where to be within this range. It just has to be in that range somewhere. So for an exam question, there'll only be one choice that actually falls into that range. It's not like I'll give you one that's 50%, one that's 75%. There'll be one in that range, and all the other ones will be outside of that range. So that's really the key. And then finally, the maintenance dose. Don't get too concerned about this. I don't expect you to know, well, not necessarily not know, but maintenance dose is a little tricky because you end up usually giving the patient access to more than they would need. So 10% would only be 12 milligrams of oxycodone. Well, that's not very much. One Percocet tablet, which is oxycodone acetaminophen, is 5 milligrams of oxycodone. So that's 2 Percocets in a day that they took that would almost get them to that 3, and they're over that. So the maintenance is really going to be pretty standard for most patients. They're going to be on some sort of every 6 or every 4 hours as needed short-acting oxycodone, short-acting hydromorphone, maybe short-acting hydrocodone, acetaminophen product like a Norco as well. But those are going to be the common ones, and the patient's going to get access to more than they would need. And the whole point of that is so that you can assess how much they're using. Are they using 1 to 2 a day? Are they using all of the available amount? Are they using 2 tablets every 6 hours? Well, that's a pretty heavy sign that you might need to go up on their maintenance dose, or figure out what's going on and why they need so much more than you anticipated. So those are just things to consider with that. As far as the as needed emergency use that goes on top of the maintenance long acting, just remember that it's a kind of an as needed option, and I'm not going to test you specifically on, well, what exactly would 10% be, because it'd be impossible to get somebody exactly 10%, and you aren't assuming they're going to use exactly 10% every day. They might use way less, they might use more, and again, that's how we assess how effective our baseline regimen is. The point is that you're giving them something that they can use on top of their existing regimen in case they have breakthrough pain, and that's really the whole concept of the PRN option. So don't get too hung up on the 10% rule. It's sort of just a loose guideline, not necessarily a firm rule that we follow, and it's not as important when compared to the whole calculation converting their maintenance regimen. So we just kind of talked about these 2 points, and then of course side effects. At a certain point, sedation might catch up with the patient if they're taking too many opioids. That's something we want to check, and certainly be really careful with those high dose extended release products, as they can cause a substantial amount of sedation. Once the patient takes them, it's in their system for 12 hours before coming out. If they're overly sedated and still in pain, possibly consider using a different opioid that might work better for that patient. You never really know if switching the agent would solve that problem. Otherwise, adjunct options would be good, and we talked about some of those, but making sure a person's using acetaminophen or using an NSAID if that's indicated. Okay, now talking about osteoarthritis. So osteoarthritis has a number of applications to some of the medications we just talked about, so that's why I think it's a good thing to go through as a separate module. But it's also one of the most common pain syndromes you'll encounter in basically any type of practice you work in. There's a lot of different things that play with osteoarthritis. It could involve things like genetics or inflammation or joint-specific problems, mechanical forces, and it's certainly associated with age as well, as people's joints break down over time from wear and tear. It'll affect different people very differently as far as different joints, different locations, multiple versus a single joint versus location, and that could present challenges in and of itself. Some areas are a little bit easier to treat because of the way we can maybe get intra-articular injections or apply topical products versus some areas that might be more challenging. Maybe idiopathic as well. You might have osteoarthritis without really any reason or rhyme to it, but that's usually a rarer case. I would say most of the time you can probably pin it on something like this. And then, of course, there's secondary case sources as well, things like trauma or bone diseases. Diabetes can cause complications as well, but that's usually more neuropathic pain. So we want to relieve joint pain, we want to control inflammation and swelling, and help the patient retain their functions of their daily living. As far as what we do with osteoarthritis, there's not really anything we're giving patients pharmacologically that's going to prevent disease progression, or basically just managing symptoms. There is some research and development about specific disease-modifying agents, but there's nothing on the market that really approaches that right now. So it's more or less just focused on managing symptoms correctly, and outside of that, there's very few options. Now, rheumatoid arthritis is a different story, but for osteoarthritis, that's the case we're looking at. And just the basic mechanism, right? You've got a breakdown of cartilage over time, and thinning of cartilage. Bone kind of grinds against bone and causes inflammation and pain. Okay, so a couple different ways we can approach basic osteoarthritis. Mild osteoarthritis usually involves low levels of pain or fairly intermittent pain. Usually patients aren't having significant interruptions in their day-to-day living. Their joints are functioning fairly well. They just have a little bit of pain. Exercising the joints and weight loss can sometimes help. That might be easier said than done for certain patients, but that is a good option for patients who have osteoarthritis. Of course, you don't want to overexert a joint that's already in pain, but to do some maybe physical therapy referrals or things like that if you want to, or recommend some exercises yourself if you're more versed in that. But those are things that you could potentially recommend for the patient. Obviously, losing weight will take pressure off the joint as well, especially if it's like a knee or a hip or something like that. But again, that's a little easier said than done for a lot of patients. Some of the great initial therapies are topical, so why give somebody something systemic if you don't have to? Topical diclofenac, which is Voltaren gel, the brand name, we talked about in the last lecture. That's a great option to try right away. You minimize the systemic NSAID response and you get the drug right to the source where it's needed. It's a very effective treatment, very popular treatment. We didn't really talk, I don't think we talked at all about capsaicin, so I'll mention this very briefly. Capsaicin, sorry, my picture kind of got a little aggressive here. Capsaicin is the active ingredient in, well, not active ingredient, I guess it depends on how you want to look at it. It's one of the ingredients in spicy chili peppers that makes them hot. And they found that it actually has anti-inflammatory effects as well. So capsaicin in a topical format in a very small dose actually works pretty well for mild osteoarthritis. So that's something that you try too. Now, because it is sort of a hot pepper derivative item, you want to be really careful with capsaicin and putting it on places that are sensitive. So like thin skin, mucous membranes, genitals, things like that. So those are probably the two places I would maybe consider right away versus, especially if the patient's open to topical. If the patient doesn't want to deal with topical products, you might want to just go straight to oral. And that's not going to be uncommon. There's a lot of patients that even if they're open to topical, they might just not be compliant with it. It's hard to remember to put on something every day versus just taking a pill. It's a lot easier. So acetaminophen, excuse me, is the preferred option for first line. Now, there's a lot of debate over whether acetaminophen even does anything at all, but it's a relatively harmless drug to try, assuming you're sticking within the recommended dosing frequency and amounts per day. So if the patient has intermittent pain, recommending as needed Tylenol or acetaminophen will be a good option for them, and then increasing the dose to scheduled as needed. If they're having regular pain throughout the day, it's okay to just start at scheduled and just say, all right, just start at 4 grams a day. And I do recommend just going big or going home with Tylenol. I think I see a lot of people coming into the hospital and they're like, yeah, I take, 325 milligrams when I need to. And it's like, well, that's like the minimum dose of Tylenol, and you can't really, it's hard to assess it. So there's really not a lot of harm unless your patient has hepatotoxicity already or cirrhosis or something like that. But that's going to be an unusual case. For most patients, giving them, going right up to say, take a whole gram, do it as needed at first, or, take it up to 4 times a day if you want to. There's very little risk with taking the full 4 grams per day for the average patient. Even to get toxicity, you need to be like to 7 to 10 to 12 grams a day is what they're looking at for overdoses. So you're relatively safe with that 4 gram, even though that's the upper limit. That's probably what you should target if you're looking at treating somebody with just an acetaminophen regimen for osteoarthritis. The other really nice thing about acetaminophen and NSAIDs as well is you should know if they work basically right away. Remember, these aren't really modifying the disease at all. So, you can maybe make the argument that over time, an anti-inflammatory drug like an NSAID might decrease inflammation more and more as the person takes it more regularly. But at the same time, you can also see that these effects should be apparent fairly early into the dosage. So once you take acetaminophen, it gets into your system, 30 minutes or an hour, or maybe 2 hours, depending on if you had a big meal or not, you should be seeing the effects of that. So you should be able to assess whether the patient's getting any relief from acetaminophen, the day you recommend it. If they don't, you can move on to an NSAID. I don't think you need to give it a week or anything like that. If the patient doesn't, get anything from it, it's probably safe to move on at that point. But that is a nice advantage where, a lot of the medications we talk about, a lot of the disease states we talk about, you're looking at multiple days or weeks of trials, whereas with pain, a lot of the time we're looking at, short, especially if we're just looking at symptomatic relief, you're looking at short intervals to trial different treatments. For more moderate to severe pain with osteoarthritis, it's probably best to go straight to NSAIDs. That doesn't mean you can't try the topical therapies as well, but usually for people with more severe pain, especially if multiple joints are affected, you probably want to stick to a systemic NSAID. And usually you're going to go right on a schedule. So with mild osteoarthritis, intermittent pain is likely to be part of it, or maybe intermittent, more increased flares of pain. But with moderate to severe, it's going to be more persistent pain. And so usually we're going to be looking at an NSAID regimen and a regular one. So the idea here is pivoting from basic pain management to suppression of inflammation. So with NSAIDs, you're going to get some analgesic relief, hopefully, just like with Tylenol, within a couple hours of taking them. However, you're looking at a couple weeks to fully assess the efficacy if you're trying to achieve those anti-inflammatory effects. And then adjusting your dose and going to those higher doses as needed. Remember, NSAIDs have that analgesic ceiling, which is fine for just basic pain management. And if you have a patient maybe in the mild category who had intermittent pain and Tylenol wasn't working and they didn't want to do a topical, or the topicals weren't working, you could switch to maybe an as-needed NSAID for those people, but at an analgesic dose. But for these patients, if the analgesic doses aren't working and there are signs of inflammation, then I would suggest looking at a more long-term scheduled NSAID regimen to see if you can suppress the inflammatory component of the disease. Pretty much every study out there for osteoarthritis and any pain syndrome shows that NSAIDs are more effective than acetaminophen. That's pretty well established. There are risks. We've talked about a lot of the risks, especially in elderly patients who have maybe diminished kidney function or might be more at risk of getting a GI bleed. Remember, those are two kind of big ones we think about with NSAID therapy, so keep those in mind. There's a lot of patients that simply won't qualify for NSAID therapy because they're on, an anticoagulant or whatnot, but it doesn't mean you should automatically rule them out. It's just you're going to run into a lot of roadblocks with NSAIDs just because of some of the contraindications and precautions around them. If you're going to give an NSAID regimen, Remember, one of the rules of thumb is protect the GI tract, so either try your COX-2 selective NSAID or give your scheduled NSAID with a proton pump inhibitor. So these drugs we haven't talked about, we're going to talk about them soon during the GI lecture, but they suppress stomach acid production and they will prevent or help prevent ulceration during an NSAID therapy. For the COX-2 selective NSAID, celecoxib, you could give a PPI, and in fact, I think generally people do prescribe them together, even though technically you probably don't need to. I think just the minimal risk that adding the PPI and the possible benefit of preventing a GI bleed is there. So generally speaking, no matter what the NSAID is, you can probably just consider that a rule of thumb. Scheduled NSAID, whatever it is, COX-2 selective or not, give it with a PPI. Okay, so there's not really any evidence that says any NSAIDs are better than another. So what I would recommend is starting with something basic that's easily available to patients and we have a lot of good evidence and use with, and then maybe moving on to some other ones if those don't work. So naproxen is probably the best choice from a number of angles. It has a low cardiovascular risk. It's inexpensive. It's been on the market forever. And it's a long-acting drug that doesn't require an extended release formulation. So with naproxen, you have a twice daily dose administration compared to like ibuprofen, which is probably the other really common starter NSAID, which is every 4 hours, every 6 hours, excuse me. So 4 times a day is what you'd take ibuprofen for. So you're taking double the amount. So when you see those silly commercials for Aleve and they, advertise that, you take a couple pills compared to a whole bunch of ibuprofen. Well, yeah, that's technically true. It is a longer acting NSAID. Some people will say naproxen is a little bit less potent than ibuprofen. So people might not get a full response from it like they would with a different NSAID, but I think it's a great starting option for a lot of patients just because of that long-acting duration and the lower side effect profile, or the better side effect profile. It also has a pretty low GI bleed risk compared to some other NSAIDs as well. Other starting choices, ibuprofen is a great starting choice. Again, just more frequent intervals. It might be a little bit more of a potent option compared to naproxen, though. Diclofenac, meloxicam. Meloxicam, remember, is once daily. That's a nice one for people who are going to start a regular regimen on. It's a popular choice for that. If those don't work, try other NSAIDs. Celecoxib is certainly an option, especially if the patient has higher GI bleed risk factors. Maybe consider that one as your go-to. Otherwise, you can go really any direction with NSAIDs, but these are kind of the ones I would start with. Topical products. So we talked about these, and again, we talked about diclofenac gel and capsaicin already. So I'm not going to really rehash these, but they're here for your convenience. If there is a neuropathic component, lidocaine patches might be helpful, but likely not going to be really great for osteoarthritis pain. It's more for like herpetic neuralgia, so people put them on their back and things like that, but not necessarily going to be like a joint-related product that you're going to use. Duloxetine. So we haven't talked about duloxetine yet because it's an antidepressant, technically. Duloxetine inhibits serotonin and norepinephrine reuptake in the central nervous system. We're going to talk about this mechanism and the mechanisms around antidepressants and depressive syndromes during mental health later this spring. But I did mention this now because it's become quite a popular choice to prescribe people for osteoarthritis. So duloxetine and to some extent some other antidepressants with similar mechanisms have gotten some interest in recent years because of their seeming ability to suppress pain. And we don't really understand why, but where they started using these drugs is for neuropathic pain specifically, and they caught on for that. Now, duloxetine actually has some interesting evidence not only for neuropathic pain, but for all types of pain syndromes. And specifically, there's been some good evidence for osteoarthritis as well. And it's actually made its way into some of the recommendations to be a prescribed option for patients with osteoarthritis. So this is really different from the rest of the medications we try. And I want to be specific, this doesn't really have any disease-modifying effects, but it is a completely different mechanism of action compared to a NSAID or acetaminophen. So you can combine it with NSAIDs, you can combine it with acetaminophen, you could combine it with topicals. So it's a nice add-on option that's relatively well tolerated. Cymbalta doesn't have a ton of side effects. And again, I'm not going to get into it a ton other than we'll talk about duloxetine and sort of the class effects of serotonin, norepinephrine reuptake inhibition when we talk about antidepressants. But overall, very well tolerated medication, effective and well established therapy for people with moderate to severe osteoarthritis and multiple joints affected, and specifically for those patients with contraindicated NSAIDs or ineffective therapy with NSAIDs or acetaminophen. This is an option that you could give somebody that really doesn't maybe have another choice. Because if you have a patient who acetaminophen is ineffective for, they're contraindicated against NSAIDs, maybe topical products aren't working, or they're multiple joints and it's just impractical, you run out of options really quickly with this. And then you look at other things that are less ideal, like, right, you start thinking about, well, what about like a tramadol or even an opioid or things like that, and that's roads we try not to go down if we can avoid to. So this is a nice choice for people in that situation. And again, you can use it really at any point in the osteoarthritis. Once somebody kind of meets that moderate criteria, it can be an option for them. So consider this. It's really a popular drug for that reason. In fact, I think I would bet easily that this medication, even though it's a fine antidepressant, it works just fine, it's much more popular because of its uses in different pain syndromes. It was one of the best-selling drugs while it was brand name for several years in a row because of its cross indications there. Intra-articular steroid injections are considered if you have moderate to severe pain not relieved by oral NSAIDs or acetaminophen, or if you have NSAIDs contraindicated. These are short-term relief options. They're going to wear off, and generally speaking, you get diminishing returns every intra-articular injection you give. People will usually see a benefit about 2 weeks after the first injection, and then they kind of wane after that. And you're going to repeat injections at 3-month intervals if indicated. And again, diminishing returns are common with steroid injection. The two steroids, we talked about these last fall. Triamcinolone and methylprednisolone are the two common ones that are given. And they come as a special depot formulation that's like this oil-based injectable that's only designed for joints. So basically, you inject it into the joint space, it stays in there. It doesn't really get in the body anywhere. So the nice thing about that is you don't really have any systemic steroid-related side effects to worry about. And I'm not an expert on dosing these things, but generally speaking, larger joints are going to require larger doses. But again, you're just basically injecting a insoluble suspension into that intra-articular space to decrease inflammation at the source. Okay, glucosamine and chondroitin. I mentioned this because it's a really popular over-the-counter supplement. I know I haven't done an OTC lecture yet. I have one slotted for the summer. Just to talk about supplements and things like that. But I wanted to put this in here just because this is really one specifically that focuses on and advertises itself as joint. You can see Cosamine DS, one of the popular brand names. It's a joint healthy supplement with an exclusive formula. It's pretty controversial as far as there isn't really any evidence that says this does anything. However, like a lot of supplements, there's not really any risk to using it. Funny, I just give a side note here about supplements in general. I work with a couple physicians, and some of them are more cynical than others, but one of them always was like, there's a reason supplements are safe, right? Because they don't do anything. Drugs that do things have side effects. It's just the nature of a drug that's effective. And it's kind of true in a lot of scenarios, in a lot of, if you think about a lot of medicines that work effectively for some indications, they likely have side effects associated with them because they are effective for certain things. So when you have a medication that's really has no evidence for its use, but it's safe, you get people who use it and you're like, well, you kind of turn a blind eye to it. But my point is that recommending this as a provider, I wouldn't really expect results from this particular product. If patients want to take it, I don't think there's any problem with that. People have always wanted to have some sort of self interest in their own healthcare, and that's fine. We want people to be partners with our patients, of course. But people will try and manage things on their own and try and go over the counter and buy something quote unquote natural, even though there might not be any evidence that it works. So I think it's important for people to understand that this isn't like going to prevent their pain. It's not really going to do much for them, but if they want to take it, it's not going to cause any really adverse effects. There are some studies, the smaller studies, maybe smaller groups of patients with very limited patient population diversity as far as things like that go. You might see some mild preventative benefits, but that's about it. One of the things that's interesting about this, it's really the only drug, quote unquote, on the market for osteoarthritis that people will use as a preventative option. There's this isn't really something you would take as needed for pain. You should, if somebody's doing that, they're doing it wrong. That's not the idea here. The idea here is that it prevents cardio degradation and also stimulates proteoglycan, so cartilage production as well. Again, not really any evidence that says it actually does that, or to at least a clinically appreciable extent, but it is something you'll see a lot of people taking because it's such a popular drug. And again, there's a lot of marketing behind that too, but I wouldn't expect good results from it. You might get patients who really respond well to it. You never know, but I wouldn't hold my breath if I was recommending this particular option. Okay, so osteoarthritis, just to summarize quickly, your initial treatment for non-inflammatory osteoarthritis is going to be acetaminophen, topical products, and then focusing on some lifestyle modifications. That's really it. If acetaminophen isn't working, or you're going into that moderate to severe being inflammatory, multiple joints affected, you're going to go straight to NSAIDs. Tylenol or acetaminophen just really isn't going to do much for inflammatory-based osteoarthritis. So naproxen, ibuprofen, other NSAIDs, remember duloxetine, and then possibly steroid injections. I think, I'm not an osteopath, so certainly I'm speaking outside of my scope a little bit, but I believe that one of the positive aspects of a steroid injection is if, like, you have somebody who has fairly debilitating pain in a joint, let's use knee pain, for example, and you're going to be giving them a joint replacement, so that's kind of the final option here. That could be a bridge to the joint replacement. So you could give them that injection and hopefully they can get by long enough before they get that joint replaced. But that's only going to last so long because of those limited time that those drugs work intra-articularly, and then ultimately the diminishing returns that happen with the repeated doses. So eventually, if somebody's at that point where they're getting steroid injections, it's probably getting close to needing a surgical option, just because that's not sustainable. And then opioids ultimately would be frowned upon. We don't like to use opioids if we don't have to in any situation. But you may have a patient that, again, might be in so much pain leading up to a surgery or an operation that they need opioids to function. And that's an unfortunate situation that we do find ourselves in from time to time. So they are there. They do have a use, but you do have to be judicious about how you use them and think about, like, what's the end goal? Because you certainly don't want somebody on an opioid forever. So making sure that there's some kind of a plan, if you're going to use opioids, that you have a plan to relieve their pain and some other strategy. And again, that's likely going to be a surgical solution. Okay, moving on to RA. Rheumatoid arthritis and osteoarthritis, there's a number of differences between them. Biggest thing is that rheumatoid arthritis is an autoimmune disease, and it's going to affect younger patients. It's not going to be age-related, generally speaking. And usually patients are going to have bilateral symptoms, so not just a single joint affected, and it's going to affect things other than their joints, like you would see with osteoarthritis. So treatment is focused on control and prevention of joint injury. Our total treatment strategy is very different from osteoarthritis. So the idea of talking about these together, the only thing they really have in common is the word arthritis. Otherwise, it's quite a bit different. And of course, if you look at it from a basic perspective, you can have similar issues within the joint space. So there is some similarity, I suppose. But with rheumatoid arthritis, our whole idea is focusing on what's called a DMARD, or a disease-modifying anti-rheumatic drug. And so I mentioned these briefly during the psoriasis lecture because they all are kind of the same. Autoimmune diseases, there's a pool of drugs, and some of them are specific for the indication, but a lot of them cross over into different areas. So drugs for rheumatoid arthritis are used for psoriatic arthritis, are used for Crohn's disease, and there's a couple other applications too. There's some oncology-specific immune-related indications for these things, and some multiple sclerosis-related things, lupus-related indications. So you get some more odder diseases or less common diseases there. But the point is, they all kind of fall into the same bucket. So this is the first time we're really talking about them. This is specialist-driven care, so somebody who does have rheumatoid arthritis should be following up with a rheumatologist, but certainly you guys as PAs can work in any specialty. I've said this before and I'll say it again, like we have PAs in every specialty of the hospital that I've seen, from infectious disease to orthopedics to whatever you want, name it. We have PAs working there. So I really want to make sure you guys understand a little bit of this, even though it is specialist-driven care, and if you're going into primary practice, you probably won't ever prescribe these, but I think it's a good idea just to have an understanding of them and being able to recognize some of the basic treatments, because RA is a relatively common disease, especially among the autoimmune diseases. It's one of the more common ones. And while you aren't going to see it to the level of osteoarthritis, you will see it in your practices no matter where you are. So identification and referral to an expert is really important. I'm not going to get too much into that. That's where your clinical medicine, decision making, etc. comes into play. Tight control of the disease is really important. The cool thing about RA is that if you treat it correctly, you can actually control it pretty well. Now, not all patients will respond, but we have some really good drugs within the autoimmune space right now that, I wouldn't say cure RA, but they do come pretty close to preventing any RA symptoms from emerging, which is pretty great. Drugs that we talked about for osteo, like NSAIDs and even intra-articular injections, or to the point of maybe systemic steroid injections, may come into play as well to help with symptomatic things, especially if a patient is having profound symptoms initially and you're waiting for the DMARD to really take effect. And these can take a few weeks to even months to start working. So bridging somebody with NSAIDs or systemic glucocorticoids might be an option. One thing I didn't say, and I'll just mention this briefly while I'm talking about glucocorticoids, is with osteoarthritis, I didn't talk about them specifically, but you will see people use low-dose glucocorticoids occasionally systemically for osteoarthritis pain. And again, this tends to be more for people who are pursuing a surgical option or have some sort of planned end game, because you don't want to give somebody on steroids forever, kind of like opioids. It's not an ideal situation to just have somebody on a steroid course that's not tapering. You want to do short bursts if you have to, but ultimately you're going to be trying to do something else. So I should say that glucocorticoids are occasionally used systemically for osteo. I just want to mention that very briefly before we move on. All right, the non-biologic DMARD options, these are older drugs that aren't really, they still have some use, but not are as common. So hydroxychloroquine is probably one that everyone's familiar with right now, especially with its kind of the craze that happened regarding its use with possibly being effective for preventing or treating COVID. It was basically shown not to have any effect on COVID, whether preventing or treating. So, but there was a frenzy there where everybody in the country was, there was some basic evidence that came out showing that it might have some effects, and everyone in the country was trying to buy it up. I think at one point we had like 10,000 doses at our hospital, something ridiculous like that, and I don't think we used any of it. So it became something that was early, but we learned quickly that it really doesn't do anything. But it is historically has a couple other uses. It's an anti-malarial agent, and it's used as a sort of interesting mechanism to prevent inflammation by inhibiting neutrophil and eosinophil chemotaxis, which prevents inflammation in certain areas. So why that does anti-malarial effects, I'm not entirely sure, but it does have some effects on suppressing the immune system on more of a broad spectrum. It's not the greatest drug. It's not one that a lot of people with RA take, but some people might be on it, and especially if maybe they were prescribed it, maybe they were started to be treated with it
decades ago or several years ago before some of our newer agents came out and it worked effectively for them, they might still be on it. But I don't think we're starting a lot of patients on hydroxychloroquine anymore. I could be wrong. I don't work in rheumatology. I'm just kind of going off based on what I read. But from what I can understand, the focus is heavily on biologic agents now, if we can get the patients to them. And there's some questions there, and we'll talk about those in a little bit. Sulfasalazine is really not going to be used often. I just put it on here because it's technically considered a non-biologic option, but it's actually more useful for GI-related disorders like inflammatory bowel diseases such as ulcerative colitis, and we're going to talk about that during GI a little bit more. You can, of course, use the NSAIDs and glucocorticoids in combination with these if you want, and you're looking at about 12 to 24 weeks. So that's quite a bit of time. You're looking at almost half a year until you can really assess whether or not your drug has worked, which is going to be a significant amount of time for somebody to wait, and a significant amount of time to give somebody steroids if they're only being able to manage their pain with systemic steroids. You can see substantial side effects in that amount of time, and then tapering them off will be a process in and of itself. So ultimately not ideal for a number of reasons. So one other drug that's oral that's used somewhat frequently for immune suppression is methotrexate. We talked about methotrexate briefly during chemotherapy because it has some chemo-related indications, but technically methotrexate is kind of, if you want to think about a first-line option for autoimmune disorders, it's going to come up quite a bit when we talk about these different diseases. And methotrexate has a faster onset than the drugs we just talked about. It can be combined with other DMARDs. So you could technically, before the biologics existed, methotrexate was the go-to drug for these indications. So methotrexate plus hydroxychloroquine and sulfasalazine was considered triple therapy for a number of years. But again, a lot of this has fallen out of favor a little bit, and we'll talk about what we currently do in a more modern practice. But anyway, this is a really common option to try orally, especially if somebody can't afford biologics or their insurances won't pay for it. The insurance might dictate that we try methotrexate first before it will authorize a biologic. Now, again, I don't know exactly how common that is anymore. I think as biologics have gotten more proven as far as giving people better benefits, ultimately you're probably seeing some cost savings on the back end, even though the drug's really expensive. But at the end of the day, the insurance might have a different idea of how effective methotrexate might be. Now, methotrexate has a lot of issues with it. It's got some interesting dosing strategies. For methotrexate for RA, you actually just dose it once a week and take it orally. You can also give it IM, so it comes as a shot too if you don't want to take it orally. It causes some myelosuppression, liver dysfunction, pulmonary fibrosis, and GI-related issues. It's not a well-tolerated medication. In fact, about 20% of people who take methotrexate will discontinue it after 2 years, and 35% will discontinue it after 5 years. Most of that has to do with the GI-related issues, because while the other things can be problematic, certainly the GI-related issues are going to be what affects people on a day-to-day basis. And that's where you might be able to say, well, the insurance rejected my idea of prescribing you a biologic agent because they wanted you to try methotrexate. Now you have profound diarrhea. Well, let's see if we can get that authorized to do methotrexate, and you can work with the insurance company if you're having intolerance. But sometimes the insurance companies, it's not like they're trying to be evil. They're just trying to find the most costs. Well, I don't know. You could maybe argue one way or the other with that, so I'm not going to get into that debate. But I like to think people try to do the right thing for patients, regardless of their company or an individual provider. And so I think what the idea here is, let's say, well, let's try this really cheap option that we've used for years that we know works. And if that doesn't do it, then we'll give you the more expensive one. But we want you to try this one first. So it's not unreasonable, but that's just the way medicine works in our country. And in pretty much anywhere in the world, you're going to run into formularies, whether it's through private insurance or through like a national formulary like you might see in more socialized medicine countries like Europe. They're still going to have options that they're going to make you try before you can try something more expensive, generally speaking. So anyway, that's a long-winded way to talk about methotrexate, that it's really going to depend on what type of insurance the patient has, what type of practice you're in, and how aggressive they want to be versus maybe trying an older drug versus going with a biologic agent. Okay. There's also a drug called leflunomide, which I don't really care you know a ton about. It's basically a methotrexate alternative, and it's comparable. It's got the same side effects. It's just, yeah, you're rarely going to see it. All right, and then you have the tumor necrosis alpha factor. So this is the first biologic category we're talking about. So these are the newer ones to the market, although they have actually been around for quite a while now. I mean, at least we're talking 10, 15 years. So we have quite a bit of experience with them. They were super expensive. They were when they first came out. They still are, and they always probably will be much more expensive than an oral therapy. Even if we were starting to see not necessarily generics, but I talked at the beginning of the year about biosimilar products, and that's what you're seeing as companies make kind of a similar product. It's complicated, but you can't really make a direct generic of a biologic agent. So anyway, you have what's considered the best drugs out there, but for this particular disease, but they're expensive and they require injections too. So that might turn some patients off. You might have a patient that just says, "Well, I don't care if that's better. It's injectable. Give me the oral methotrexate, and I'll see what happens with it." I say always be second line to methotrexate unless cost decreases. That's kind of an old statement. I don't really know how to update that specifically because it's going to depend on what you said, or insurance dictates is probably a better way to say that. Anyway, there are a lot of these drugs that are on the market. Some of them have different niche indications. So some might be specifically developed for Crohn's disease. Some might be specifically developed for psoriatic arthritis, but they all basically do the same thing. And the big ones for RA are etanercept, which is Enbrel, adalimumab, and infliximab, or Humira and Remicade. These all sort of have some different things. Like Remicade is an IV-only infusion, so you'd have to go to an infusion center to get that. Enbrel and Humira are take-home injectables that you can do, in a kit at home that are just sub-Q. There's some newer agents on the market too. Certolizumab, golimumab are there too. If you notice, the MAB here is pretty consistent with the exception of etanercept. MAB stands for monoclonal antibody, which is what these drugs are. So that's how you can always, if you ever see a drug that ends in MAB, as far as the name goes, you can know immediately. You should think, oh, that's a biologic agent. That's something that probably is used for a autoimmune disease. Now, that's probably something you can take to think, or chemotherapy. Those are going to be the two indications groups that we're going to see MABs used for. So a lot of these times people just refer to these drugs as MABs, or monoclonal antibodies, because that's what they are. So you can kind of just ignore the rest of it, and if you can recognize MAB, you'll probably be okay. That's all you really need to know for my class, is if you can recognize, oh, adalimumab, MAB, yes, or etanercept's kind of the oddball. So but all these are popular choices, again, depending on sort of which direction you want to go with the patient. Infliximab, probably not as popular just because it is IV, and this was originally designed for Crohn's disease, but anyway, that's neither here nor there. All right, talking about these a little more. So Enbrel or etanercept is one of the more popular choices for RA. It's really well tolerated. It's usually was designed as a option for patients who fail methotrexate. But it actually has been shown to be modestly more effective than methotrexate and quicker results than methotrexate. So because of some of these reasons, we're quickly seeing these drugs replace methotrexate, and people are wanting to use these more as first-line options. And it makes sense, right? You have better results, you have better evidence that they're just better drugs altogether. The biggest side effects with monoclonal antibodies and drugs like etanercept, I should say, tumor necrosis alpha factors. And I'll talk about, I have the mechanism here. I think I have the mechanism on another slide. Sorry. I'll talk about that in a second. But the biggest thing about these is that you're going to suppress the immune system to a certain degree, which usually doesn't make you more likely to get things like the common cold or anything like that. People actually don't really have, you don't think about it as immune suppression like from a transplant medicine point of view. But what you're going to get is maybe baseline underlying infections that you might have. So that's why you always have to do PPD tests to make sure you don't have tuberculosis or latent hepatitis, things like that, that might emerge if you do give somebody one of these drugs. Otherwise, people generally don't have much of a side effect with them. But remember, the thing about biologic agents is that they have a more high I should just say higher propensity to cause a immune-like reaction when you give them. So people are more likely to get an anaphylactic response with one of these agents than they would be like your standard oral agent. Other than that, very well tolerated, very low side effect profile. Adalimumab or Humira is the less antigenic, so it has a little bit more of a decreased risk of causing that anaphylactic response we're worried about. And it's basically the same concept, though. Better than methotrexate, kind of on all cylinders, and it's about the same amount. So this is once weekly at $700 a dose. This is every other week at $1,500. Same basic cost. Infliximab is only approved for use with methotrexate, so it's not a individual. You aren't supposed to use this one by itself, and it's IV only, and every 8 weeks after the initial loading period. So if you wanted somebody to come into infusion center, or if somebody has home care, something like that, it might be an option. But overall, probably going to pick one of these two instead. The other ones that are on the options that are sort of non-tumor necrosis alpha factor biologics, there's a bunch of them, and of course this is a hot market right now for drugs, so there's a whole bunch of things in here, and these aren't necessarily designed specifically for RA. A lot of them were probably designed for other things like broad spectrum immune suppression or chemotherapy related indications, and they found that they work for RA for patients who aren't responding to other things. So I'm not going to go through these. I don't care that you know them, other than just that there are other options that exist out there. One to remember, this was a heavily advertised drug, and I think these kinase inhibitors, there's different types of kinase: tyrosine kinase, Janus kinase, or Janus, I don't know how you say that, but the drugs that end in nib or inib are often used for different types of immune diseases or chemotherapy applications. And the big difference between these and something like a tumor necrosis alpha agent are that they are oral. So these are small molecule drugs. They're non-biologic. They are disease modifying, and there's a couple on the market right now. Xeljanz was the first one to come out, and there's a few others that are indicated for RA. I don't care you know all their names, but if you can recognize the NIB, you'll be okay, I think. So remember, we've got three different types of DMARDs we talked about, just to review at this point. So we've got methotrexate. You've got the early ones like hydroxychloroquine. I really don't care you know those, because I don't think they're really recommended anymore as first line. So you've got methotrexate, you've got your MABs and etanercepts, put those tumor necrosis alpha factor drugs in one bucket, and then you've got drugs like these newer ones that are coming out, the Janus kinase enzyme inhibitors. And what those enzymes do specifically is they're involved in stimulating hematopoiesis and immune cell function. So by inhibiting it, you inhibit cytokine and growth factor signaling, and ultimately you suppress the immune system through kind of an interesting novel mechanism. These currently aren't recommended to be used with other biologics, and they do increase the risk of infection like other immune suppressive agents. But despite the fact that they're small molecule and not biologic, they are really, really expensive. So you would think that they're easier to make, and you're right, they are, but they're still very, very expensive. So cost savings probably not significant over an injectable, but we'll see how that pans out. So how you approach RA, again, this is kind of an old school look at it, and a more conservative approach and a more cost savings approach. So depending on where you go and who practices and what insurance the patient has, it might change. But generally what you're going to look at is somebody's going to take methotrexate as their first line choice, and they're probably going to get NSAIDs or glucocorticoids while that methotrexate is getting bridged to full effect. If they can't take methotrexate, and the big caveat being here, and cost is an issue. That's the big caveat, that they're going to be on some of these other oral drugs. These are not expensive. If that doesn't work, you're going to consider methotrexate. If like methotrexate, well, let's take a step back here for a second. So if you start them on methotrexate, and the disease isn't fully responding to it, you could consider adding something from this category. You aren't going to add leflunomide, but you could. Otherwise, you can combine methotrexate with the tumor necrosis alpha factor inhibitor. And if that's still not responding, you could drop the methotrexate altogether. You can try other biologics. You can switch to a different TNF. You can try the kinase inhibitors. Lots of different ways you can go. This is a messy algorithm because there isn't really, from what I can tell, a specific guideline to say do this, this, and this, and this. It really is going to depend on how the patient responds and depend on what type of insurance they can have. So, yeah, it just depends on where. I mean, you could probably make the argument at this point in time. Where's my there, I'm trying to get in here, that you could have a whole different tier here where you're recommending the TNF factor inhibitor right away, but that's just kind of pie in the sky right now. And that's where I think these autoimmune diseases get a little more controversial, because some diseases, like I think in Crohn's, it's much more aggressive to put people on a biologic faster. But with RA, I think methotrexate still is keeping the standard going as far as let's start methotrexate and see if we can move on from there, add something on from there. Okay, finally we have gout. Gout, just basically, kind of going to go through this quickly. You have usually a single joint affected. It's caused of uric acid buildup and crystallization. This is usually related to obesity, inactivity, high amounts of alcohol and protein consumption. It's called the disease of kings, because I think of Robert Baratheon from the Game of Thrones or A Song of Ice and Fire as kind of the hallmark gout candidate. But I know he didn't have gout in the books, and actually another person did. But that's not a little bit of trivia there. Anyway, the point is that I think of that as like kind of your standard gout candidate as somebody who would have it. And so it's a relatively common thing that happens to people just because inactivity, obesity, and high protein consumptions in American lifestyle and diet tends to be, unfortunately, maybe a little more common than it should be. You have a couple options available. There's basically three choices to treat a gout flare. There's NSAIDs, there's colchicine, and glucocorticoids, and you can combine them potentially. There's also some biologic agents that are super expensive and may be used for like last line therapy that doesn't respond to anything else. Ideally, with gout, you're treating a gout attack as soon as it's coming on and continuation for the duration of the attack, and then probably stopping about 2 to 3 days after complete symptom resolution. Usually this lasts about 5 to 7 days total if you start it within 12 to 36 hours of symptom onset. The longer you go, the harder it is to get anywhere, and eventually the gout flare should go away on its own. There are also some chronic medications that are used to prevent gout flares. They don't really do anything during the attack, but you don't stop them. You just kind of continue them while they go. So the two most popular treatment options are going to be NSAIDs and glucocorticoids. So people always ask me, like, what should I pick? And it's like there's not really any evidence that one of these works better than the other, and I think it comes down to provider preference. And people tell me, well, I was always taught you should do this first. I'm like, well, you can do that. You just there isn't a solid plan that says you have to give a steroid first. And usually it's going to be directed on what might affect the patient more adversely, right? So if the patient has history of GI bleeding or poor kidney disease, NSAIDs probably aren't going to be a good choice. Glucocorticoids might be a much better choice for them. So direct your therapy maybe based on what would be a problem. If somebody has like fragile diabetes where their blood sugars are not consistently in control, glucocorticoids might be more of a problem for them than NSAIDs, for example. So with NSAIDs, naproxen and indomethacin were the two that were studied most often in gout. Any one should probably work theoretically, but these are the two. And indomethacin is probably going to be the one people pick a lot because that's kind of the hallmark gout NSAID that people think about. And again, anything would be fine, but that's just what people use. Best initiated within 48 hours, and then again, the contraindications you're going to watch out for. Glucocorticoids, POIV, or you could do intra-articular too. I've never seen that done. I assume some people do that in clinic or whatever, but we usually just use oral in the ED. So patients are unable to tolerate NSAIDs, may cause mood changes, hyperglycemia. I put glucocorticoids, now this is my personal opinion here, I'd put them as second option. I think NSAIDs for the vast majority of patients should be the first choice because they're probably going to be the better tolerated ones when used in a short course. Glucocorticoids have a bit more propensity to cause short-term side effects like hyperglycemia, mood changes. Now that should be fairly minimal, but you still might see it, and it's probably going to be a little bit less well tolerated than NSAIDs in the grand scheme of things. But again, if you have a contraindication to the NSAID, I would certainly not hesitate to prescribe prednisone or another glucocorticoid. Then there's colchicine. So colchicine is a newer drug that we haven't talked about yet. So what it does is it actually specifically arrests microtubule assembly and inhibits many cellular functions and prevents neutrophil-related inflammation. It's another second or third or first. I don't. Again, gout's sort of weird, where people all sort of have their own opinions on what they should use. But I personally think that colchicine's a little bit should be at least second line on your radar. There's a couple reasons why, and most of it has to do with the GI-related side effects. It does cause some diarrhea and abdominal cramping. It's also contraindicated with strong CYP3A4 inhibitors, or if you have renal or hepatic failure. So there's going to be a lot of patients that don't qualify for colchicine based on some of these criteria. Anyway, it's not going to be the best tolerated out of the three options, which is why I put it last in my personal book. But we don't really know if it's better or worse than anything, because there's actually no trials comparing it head-to-head to NSAIDs, which is, again, interesting why no one's ever done that. I guess there's no money in researching that, and who really cares? But it is a third option, and you could consider using it if you wanted to. I'm not saying not to use it. I just think I would pick a NSAID or a corticosteroid over it personally. But you'll run into people who have different opinions on that. So I'll leave it at that. A basic gout strategy, so review individual factors, contraindications to glucocorticoids or NSAIDs, and assess your available options. So if there's no contraindications to oral glucocorticoids, you can treat with that. No contraindications to oral NSAIDs. Look at for risk factors. If there are no risk factors, you may treat with an NSAID. And if you have contraindications to both, probably look at colchicine. So this algorithm doesn't really probably help you a ton. Basically says you could use colchicine or NSAIDs, right? Assuming there's no issues with either one of those. And glucocorticoids or NSAIDs. And that's really the general strategy here. Pick an NSAID or a glucocorticoid. Again, I'm not going to get up on your case if you don't want to do the NSAID first. If you'd rather go with the steroid, fine. I don't really care. Ultimately, I would agree that colchicine should be a choice that would only be pursued if your patient didn't qualify for a glucocorticoid or an NSAID. Patient adherence would be something to consider if it's resistant or not. Flares should resolve 7 to 10 days, and again, early treatment is key. Combination treatment is done occasionally. You can do intra-articular plus oral. Colchicine, I've seen some evidence that says people will use colchicine in combination with NSAID or a glucocorticoid. I actually had a provider approach me saying that they were taught to use triple therapy, and I couldn't actually find any evidence or recommendations for people using all three together. I would not recommend doing that because I don't think there's anything that says that that's beneficial. And that seems to me like you're increasing risks for a variety of side effects by doing that. But if you did have somebody who maybe that's their fourth, fifth gout flare and the NSAID's not cutting anymore, either switch to the glucocorticoid and try that, or combine it with colchicine. There's some interleukin-1 inhibitors, anakinra and canakinumab. Those could be considered for patients with severe refractory gout flares that aren't responding, and those are going to be really, really expensive options. There are a couple drugs on the market that are used daily, chronically, to prevent recurrent gout. They don't work in acute flares. So if somebody's coming in with their first gout flare, don't be like, oh, we should give them allopurinol. No, that won't do anything. What these drugs do is they inhibit production of uric acid. So there's allopurinol, which is the old standard. It's super common. It's really only issue. It does have some minor side effects, but its issue is it's renally adjusted. So patients with renal dysfunction might not qualify. And then you have the other drug, which is newer, called febuxostat or Uloric. It's okay to use in chronic kidney disease patients. So that's really the only reason you'd use it over allopurinol. It's quite expensive. Interestingly enough, both of these drugs can actually precipitate acute gout during therapy initiation. So it's recommended that you give NSAIDs or colchicine as a low dose during the start of therapy. Hydration is also helpful, and you can also test uric acid levels if you really want to. Okay, so that's it. I've got a couple review questions here in cases that I can go through quickly. So the first is DA. He's a 40-year-old man. He's got metastatic bone cancer. He's been treated for chronic pain as an outpatient with long-acting high-dose oral oxycodone. He has been admitted for a procedure and is reporting that his pain is currently 10 out of 10. You want to start him on a continuous IV infusion. Which of the following medications would not be an appropriate option? So for this question, you're really looking at, do you know which ones don't come IV? That's really all I'm looking for. So hydromorphone, fentanyl, and morphine are all available IV. Oxycodone is only available orally, so that would be the correct choice. CP is a 35-year-old man who presents to urgent care with acute pain in his left elbow due to a recent fall in the ice while shoveling. You have given him acetaminophen and IM ketorolac while he awaits imaging. He still rates his pain as 8 out of 10. You'd like to avoid giving him a weak or partial opioid. Which medication would not be appropriate? Okay. Sorry, I had to think for a minute. I think this question is screwy. It doesn't make any sense to me. Sometimes I write things and I look back at them like, what did I mean there? Okay, so I reworded this. So again, we have this person. He got acetaminophen and Toralac. He rates his pain as 8 out of 10. You'd like to give him a weak or partial opioid. Which medication would not be appropriate? So the choices have 3 drugs. Which one of these is not a weak or partial opioid? And that's going to be hydromorphone. So this comes up a lot where you have a patient on, you've tried a couple things that are basic pain management tactics. So you've got acetaminophen, you've got an NSAID, even you gave him IM, so it's the injectable version even. Still not doing really well. So you want to give him something a little bit more, but don't want to give him the full opioid. You'd like to give him a weaker partial. So which one would not be appropriate? Hydromorphone is a full-on opioid, so that would be the one you want to avoid. Okay, sorry about that weird wording there. Okay, we've got SR, a 65-year-old female complaining of chronic joint pain in both her hands. She's been a lifelong gardener and would like to be able to continue this hobby in her retirement. She has tried an occasional Tylenol with minimal relief. SR has no evidence of inflammation that you can tell. Which option is best for SR today? You want to start a daily ibuprofen regimen, start ibuprofen as needed, start a scheduled max dose acetaminophen regimen, or start Percocet, which is oxycodone and acetaminophen, to be used as needed. So the correct answer here for this patient is going to be based on, you don't really know for sure, but I did tell you that she doesn't have inflammation. And she's just using the occasional Tylenol. So what I would say that even though she's getting minimal relief with it, I'd ask her to up her Tylenol, do a max dose acetaminophen regimen. So go with 1 gram every 6 hours and see if that helps. And if not, then you could move on to some other regimen. But I would start with that first and then look at moving to a NSAID-based regimen. So again, that's choice C would be the correct answer. Sorry. Okay, which of the following conditions would not be a reason to consider avoiding NSAID therapy? Hemodialysis, pre-hemodialysis CKD, or recent myocardial infarction and recent gastric ulcer? Give you a chance to think about this one. So this is a little of a tricky question. I just like to put this in there. I don't think I'd ask a question like this on the test, but I like to get people thinking about this. Actually, people who have completely failed kidneys are good NSAID candidates because you can't really do any more kidney damage than that. You don't have to worry really about the kidneys clearing the NSAID. A pre-hemodialysis CKD patient, myocardial infarction, gastric ulcer, we'd want to avoid them in all those patients. But if you're on dialysis at that point, you can give NSAIDs. It's just fine. Okay, LL, she's a 33-year-old female with a history of rheumatoid arthritis who presents to a rheumatology clinic. She's been on methotrexate for 3 years with good results. However, she was experiencing some minor pain flares and her dose was increased 3 weeks ago. For the past 2 weeks, she has been having significant diarrhea and nausea, lost 10 pounds. So what would be the best option here? This is a little tricky, and my goal is to get you to think about some of the different options and where you might try it. Most people would probably end up between choice C and D. And in real life, and again, these questions I ask on here are more designed to be a little open-ended than what I'd ask on an exam, of course. But for this particular patient, I think what you'd think about is two things. So first of all, do you need to stop the methotrexate whatsoever? And you could maybe debate whether or not you should do that. I think in this case, she'd been on it for 3 years with good results. So do we really want to ditch it altogether because of some minor pain flares? So I think that probably the best way to do it would be to decrease the methotrexate back to the old dose and add on the etanercept, so your TNF agent, and that's going to be choice D. You could make an argument that, well, let's just ditch methotrexate altogether and go straight to Enbrel, but most recommendations would say to keep the methotrexate on board and add the etanercept. Even though you can use etanercept as monotherapy, that's just generally what recommendations would be right now. So again, a little bit more into the weeds on the rheumatoid arthritis type treatments, but and a little more complicated than I expect you to know on exam. But it is something to think about where you'd go with some of these decision making when it comes to prescribing these different drugs for a rheumatoid arthritis patient.